So this is the first case, a 26-year-old male, stable refraction, refractive error of -15, -18, and the two eyes, thinnest Pecky 506 and 504, ACD endo is 3.05, 2.96. So because the white to white was 10.89 and the white 10.85, we went with a ICL size, and that was 12.1, and that was based on the nomogram, based on what we all follow. And when we saw the post-op picture, the vault, if you can see clearly, it is here 122 microns, and 122 microns is a vault on day one which is not acceptable. And we all know that 250 to 750 is considered as normal, and with the current generation of V4C model, we may go up to 200 microns, but beyond that 122 is too less. So we thought that probably we have gone wrong as far as the sizing of ICL is concerned, and we went for one size bigger. And we went for one size bigger, and then we found out that the vault was again 175 microns. So we thought that there is something wrong, and let's evaluate. We evaluated everything, and then while evaluating the IOL master, we saw that the lens thickness was 4.12, which I thought was more than what we normally get in our machine. So then I wanted to be sure that in our machine, in normal lenses, in normal eyes, what is the lens thickness? And we did a lot of we evaluated a lot of eyes. We found out that the average was about 3.26 and 3.28. So we felt that 4.12 is very high. And then tried to analyze the studies, and we found out that there are situations wherein you just don't have to think about white to white and the AC depth, etc. Crystalline lens rise is one factor which is very important, which came up because there can be different crystalline lens rise in different eyes, and the average normal that studies have shown is about 67 microns, and the range is about -150 to 300 microns. Now this crystalline lens rise is the rise of the apex of the anterior capsule over the line connecting the corneo-iridic angle. So if the crystalline lens rise is high, then we have to go for one size bigger. Now we thought that we went for one size bigger, but still the vault was less. So what can be the reason? The only thing that we found out that there was one more study which we evaluated, and we found out that in 81% of eyes, it's not, the foot plates are not in the sulcus on both sides. It's mostly on the ciliary body, and in only 6% of eyes, it's in the sulcus on both sides. And in the remaining 13%, it's one on the ciliary body and one on sulcus. So based on all this, we discussed with people, and we found out that the lens thickness was the culprit. And lens thickness, why the lens thickness was more? Because there was a subtle laxity of zonules. We found out this in two eyes. In one eye, we exchanged the ICL with one size bigger, still the vault was low. In another case, we saw that the vault was low, and then we evaluated, and the lens thickness again was 4.2. Then again, there was another case which was referred to us from outside, and there also the vault was low after exchange of one size bigger, and there also the lens thickness was low. And the fourth eye, when we saw, when the lens thickness was high, we did not put it. I was just discussing in one of the forums, and I was discussing with Dr. Gaurav Luthra, and he said that he has also found out in a couple of cases wherein the lens thickness is high, and that mainly is because of the laxity of zonules. And if you keep putting the ICL of bigger size, it will keep impinging on the zonules, and the vault will not increase significantly, and the patient may develop cataract later. Further, there can be zonular damage as well, and that is why in such cases it's better to explant the ICL. And we explanted the ICL in this particular case, explained the patient about clear lens extraction. Meanwhile, the patient is on contact lens. So the food for thought here is that if there is high lens thickness, apart from other things, if other things are absolutely fine, if there is a high lens thickness, you should always measure in your machine what is the normal lens thickness in your routine cases. And if it's significantly high, as was in this case, 4.12, 4.28, in when the normal value was 3.26 and 3.28, in such cases, I think we may consider it as a contraindication for ICL implantation. That is something that we have to keep thinking. And more of the refractive surgeons should come out with such cases wherein they found out like this, and then we may come up with this kind of directives. Meanwhile, we have made a manuscript of this, and we have sent for publication, and let's see, once it gets accepted, we will be able to tell you more. Then about post-LASIK epithelial ingrowth, there are three scenarios that I'll be presenting in post-LASIK epithelial ingrowth. This is a case, 30 years old, progressive diminution of vision, visual acuity 20/80. On examination, epithelial pearls were seen in the flap interface, and you can see here the epithelial ingrowth was seen. But when we examined the patient carefully on slit lamp, we found out that there were discrete opacities below the interface area as well. And then we did the OCT, we found out, although because of the dense opacity, dense epithelial ingrowth, there is shadowing here, but there were some opacities here which may not be that clear on OCT, but on slit lamp evaluation we could see the discrete opacities present in the anterior stroma below the interface area, and we made a diagnosis of a presumed granular dystrophy with epithelial ingrowth, and we went ahead with a FALC procedure. This is the post-op picture, and you can see it's absolutely clear. The clarity is there. We went for a sutureless FALC, which is femtosecond assisted anterior laminar keratoplasty, and it was clear. So then we searched the literature, and there was one case report wherein they reported that there was significant epithelial ingrowth in an eye which had minimal granular dystrophy, which was visually insignificant, had 6/6 vision in spite of those flecks. And the patient came for refractive procedure, and refractive surgery was done, LASIK was done, and the patient had epithelial ingrowth. This was the post-op picture after FALC. You can see it's clear, and the apposition of the graft-host junction is absolutely vertical and nice. We did the histopathology in order to confirm whether it was only epithelial ingrowth or a combination of granular dystrophy, and we found out that there were epithelial ingrowth in the interface that was visible on the histopathology, and there was additionally discrete multiple eosinophilic anterior stromal opacities which stained positively with Mason trichrome, suggestive of hyaline deposits of granular corneal dystrophy. So the food for thought here is that when we are examining a case for LASIK, we should definitely do a thorough meticulous slit lamp evaluation, and obviously we all do that. But in case if we get a few flecks in the stroma, in such cases it's better to avoid, although with a couple of cases we cannot develop a causal relationship. However, we can still doubt that such cases can develop epithelial ingrowth. And in such cases, if the patient requires a refractive procedure, then a surface ablation can be a better option in comparison to a LASIK procedure. Then, the third case, the second case as far as epithelial ingrowth is concerned, this was a case wherein the LASIK procedure was done in Dubai. He was actually a terrorist, a prisoner in Tihar jail, came to show to us, and there was dense epithelial ingrowth in both the eyes. When we did the OCT, we found out that the undersurface of the flap had dense epithelial ingrowth, and And when we lifted the flap, we found out that it was really difficult to remove it from the undersurface of the flap. From the surface of the stroma, we could do that. We lifted the flap and then we used alcohol over the stroma and just move. Yeah, we used alcohol over the stroma to somehow reduce the adhesion of the epithelium, debrided the epithelium on the surface. Then after that, we used mitomycin C as well. The surface epithelium, it got removed completely, but the undersurface showed thick epithelial clumps which were actually percolating into the flap. So we planned to remove the flap. We did the flap amputation, and then after that we used mitomycin C and then put a bandage contact lens. So post-op day 5, the patient had 612 uncorrected visual acuity. Now, we all have seen that flap amputation does not cause that much of a refractive surprise. It's not that if a flap is of 100 microns, then the refractive error, the hyperopia will be that much. Most of the studies have shown that the refractive change that happens with flap amputation is of the degree of 1 diopter of hyperopia and 1 degree of astigmatism, 1 or 1.5 degree of astigmatism. Sometimes you can have a hyperopia of just 0.5 diopter, but astigmatism is there. Why? Particularly in a microkeratome assisted flap, when the flap has been created by microkeratome. Why? Because the thickness of the flap, it has been seen in different area, is slightly different, microscopically different. And what happens, that flap and the stromal bed acts as lock and key. So when the flap is reposited, that irregularity in the thickness of the flap that has been created by microkeratome is masked. But when you remove the flap completely, then little bit of irregularity is there, and that is why that results in some degree of astigmatism. But however, it has been seen and shown in literature as well that once there is epithelial growth over it and epithelial turnover, with time there is a reduction of astigmatism. Now, so the food for thought here is that if you have a dense epithelial ingrowth, particularly dense in the undersurface of the flap, it's better not to keep scratching the undersurface and hope that there won't be recurrence. Rather, we can sacrifice the flap with reasonably good result. And the last scenario that I'm going to show is that sometimes you can have an epithelial ingrowth in the periphery of in the peripheral part. And most of us, we follow up the patient if it's not causing significant astigmatism, so we don't lift the flap, or it is not coming into the central part. Sometimes if there is proliferation, like in this particular case, the ingrowth was in the periphery, but it proliferated and lifted the flap and caused flap melting. In such a case, it's better to remove the flap. Now what you can do, you can amputate the flap, or you can do remove the flap and do a sutureless anterior laminar keratoplasty for it. So in this particular case, I have removed this, amputated the flap and placed it with a similar thickness of donor lenticule after removing the epithelial ingrowth completely using mitomycin C. Then I've used a similar thickness of donor lenticule, and then fibrin glue. Once the edges were dried, fibrin glue was used and a bandage contact lens was placed. Now the point here is that whether in such cases we should amputate the flap only or do a salc. Now, as a cornea person, I was biased to do a salc, and there is one advantage of doing salc. Now, even if you do a salc or you leave the flap amputated on bare area, you will get some amount of refractive error in both the scenarios. Now, if you have done a salc, the advantage is that you can do a surface ablation over it, and you don't have to sacrifice the stromal bed, the tissue of the stromal bed. So that is the advantage of salc. Otherwise, the results can be obtained even just by flap amputation. So these are some of the cases, interesting scenarios, I thought. So the food for thought is that if you have a peripheral epithelial ingrowth, the frequency of follow-up should be increased. We should not just think that it's in periphery, so it will not come into center. Once the patient comes to us with some problem, then only we will manage. We should frequently follow up these patients, because if it proliferates, it can cause flap melt. And if there's a flap melt, then you cannot keep the same flap. You have to debride the epithelium, but you cannot keep the same flap, because there is risk of flap, recurrence of flap epithelial ingrowth. So, as I said, both the scenarios, either you amputate the flap or do a salp, both will have some degree of refractive error. But if you do a salp, you have the flap area wherein you can do a surface ablation and you don't have to sacrifice the stromal bed tissue. So that's the advantage of this scenario. So thank you very much once again for inviting me here in this wonderful meeting.
Thank you, sir. I think it's always wise to know the end. And if you cannot manage the complication, we should not do the procedure. So you've really taken us to reach the end point where we can manage the complications. Thank you so much. We were really, really honored to have you here, sir. If there are any questions, or in the interest of time, I think we can move on to the next session. Our next session is More Reasons to Smile. So I think it's a giveaway. We are going to be talking about, the new technology Smile that we have. And now I request Dr. Dhami to give the momentum to Dr. Rajesh Sinha and honor him. Meanwhile, I request the panelists of the next session, Dr. P.S. Rana, Dr. Rajendra Singh, Dr. Gaurav Luthra, Dr. Rohit Om Prakash, Dr. Vikas Mittal, and Dr. Ashok Sharma to please take the seats. I request Dr. Amit Gupta.